welcome to Grand Rounds, a special Grand Rounds, and a special thanks to Kaniska Pharmaceuticals for supporting us this morning. I have the real pleasure of introducing Dr. Craig Strauss this morning. Dr. Strauss is a Minnesotan, grew up here, went to Southwest High, where he graduated as valedictorian. He then went out to Maine to a grade school, Bowdoin College, where he majored in mathematics and economics, and actually did an internship at the Federal Reserve Bank. I don't know how many cardiologists have ever done that. Graduated with high honors, summa cum laude from Bowdoin, and then went out to Boston and worked for Bain and Company as a strategist in their healthcare sector. With that experience, went out to Dartmouth and went to medical school, where he graduated with a medical degree and also a master's in public health, and graduated with Alpha Omega Alpha honors. He came back to Minnesota, came to here Abbott Northwestern, did his residency where he was chief resident, and then to the University of Minnesota and completed his cardiology fellowship. We were lucky to recruit him to the Minneapolis Heart Institute after that, and he became an executive committee member in 2014. Shortly after, he founded the Healthcare Delivery Innovation Center, which has done incredible work and is known really internationally for the work that he does and that group does in advanced data analytics. That founder of the Healthcare Delivery Innovation Center won the Innovation of the Year by the Society for Health Information and Management, HIMSS Society. Craig's done incredible work with that, and we're really pleased to have him here this morning. With that introduction, you can tell how accomplished he is, but I wanted to embarrass him and just show him what he's most proud of, his family. And this is going to work. Here's a picture of Craig, and anybody who knows Craig talks a lot about his wife and two daughters and their time in Boston. There he is. I don't know if that was pre-call or post-call with your little girl. And then people probably don't know, but Craig's passion, he has a passion for woodworking and has built incredible pieces for his home. So with that introduction, I'd love to introduce you to Craig Strauss. Craig. I think
pictures.
I don't know.
All right, thank you, Bill. It's fun to be here to sort of share where we've been and where we're going with the Healthcare Delivery Innovation Center. I think we've had a major impact on how we deliver cardiovascular care in our community, and we've really only scratched the surface of what's possible. So I want to sort of walk you through the importance of a data infrastructure and how our health system and how our cardiovascular service line has invested and can continue to invest in it going forward. Goals today are to touch on the value of an enterprise data warehouse, how data and analytics can improve operational and clinical outcomes, and describe how a data infrastructure is really a foundational component of the coming wave of artificial intelligence and how we'll deploy that technology. When you think about what's possible with a robust data analytics infrastructure, it's really phenomenal, and I hope by the end of this talk you'll look back at this slide and feel that in the cardiovascular service line we've achieved a lot of this, and that across the health system overall we haven't achieved a lot of this, and that there's the opportunity to really expand what we've done in cardiology to the broader health system. But using data-driven insights to guide strategic investments, I'll give you some examples from our joint venture partnerships, the development of our CV-dedicated ambulatory surgery center, and how we optimize our clinical network and referral network across all of our sites. We'll talk with several examples about reducing unnecessary variation in care and how we can drive clinical improvements in care, and the development of e-consults, and then how we use data-driven decisions for strategic investments in value-based care. When you think about the cost of care, and you'll see this in a few slides, we can't continue at the pace we're at with the spend that we're at. So the question is, how do we do it better? But nonprofit health systems still need to make a profit. They just need to put that profit back into the health system as reinvestment reinvestment in the community, reinvestment in the work they do. And that means strategic decisions that drive financial profitability. And finally, within MHI and within the CV service line, I think you all know, but physician leadership and clinical insight are key drivers to how we make successful and informed decisions in moving care forward. I'm going to start here with things I think you guys already know, which is that we spend a ton of money on healthcare in the United States, way more than other industrialized nations, and it's growing. You can see on the left life expectancy compared to per capita spend, and the US is a significant outlier with that red line. And on the right, the United States is a significant outlier compared to all of our comparable countries, the green line. The projected prevalence of cardiovascular disease continues to grow. High blood pressure, 27 million, about 45% of the US will have some form of cardiovascular disease by 2035. And the shortage of physicians continues to grow. We can't continue to ask physicians to see more patients, do it faster, shorter, better, because we continue to have less and less physicians compared to the demand needed with the population growth. In the cardiovascular market, our care remains relatively fragmented, certainly costly, and often reactive. We're reacting to diseases that people present with in the emergency room or in clinic, and not to proactively preventing disease or managing care over the longitudinal time frame. There's been many market disruptors, and you see them every day: private equity and venture capital deals, the role of virtual health, and Amazon and Walmart and all those folks getting in and out of healthcare, and new technologies that focus on specific conditions, whether it be diabetes or heart failure or weight management or the like. And then we'll touch at the end of this a little bit on artificial intelligence. So when we think for the Allina Minneapolis Heart Institute service line and the Cardiovascular Institute, we've thought a lot about what's the landscape look like. I mentioned, the growth of cardiovascular disease. I think anyone who practices medicine knows that the decisions we make have a huge impact on the cost of care. Whether you choose to send someone for an invasive angiogram or a CT coronary angiogram or treadmill stress test, those are very different cost structures. And when you multiply that by every decision we make, it's a significant driver of cost. When we think about the future, we want seamless transitions of care, and we want it to be patient-focused. We want to use technology where we can, and we want to use the data infrastructure that we have to make decisions around prevention all the way up to who's best for heart transplant and VADs and the like. And our HDI center, as you'll see, has leveraged that data infrastructure to do a lot of these opportunities, and yet really only scratch the surface of what I think is possible as we move forward. We've done certainly the ambulatory surgery center, which you'll see, and we hope to expand that, and the growth of virtual telehealth visits and investments in our data infrastructure. But as a health system, we're at an inflection point, and we need to make decisions about how we're going to reinvest in the data infrastructure that we have to be able to continue to do the work that we have done. Allina is a partner with Health Catalyst, and Dan Burton, who's the CEO of Health Catalyst, said this many years ago, and I think it's even more true today. As more healthcare organizations are coming to understand the future of healthcare will rely on the broad and more effective use of their vast stores of data. Some companies have figured this out: Amazon, United Healthcare, Optum, but health systems have not leveraged their data infrastructure in the same way. So we developed the Healthcare Delivery Innovation Center, and I want to highlight this is not me as a center. This is a partnership. Dr. Bradley, who's here, Pam Rush, who's one of our administrative team, Stephanie Sheldon, and certainly our Health Catalyst team of analysts who are dedicated to helping us drive these analytics forward. And it's that partnership that allows the success of what we do, along with everything that all of us do as clinicians and across the service line every day. Because what we're doing is measuring, tracking, and trying to improve what we do, but we're still providing that care every day across the system. The HDI Center has really grown, and it started with these different puzzle pieces, which you see as sort of a focus on innovation and a focus on quality and trying to reduce unnecessary variation in care, measuring patient experience, and certainly using advanced analytics to drive that. And it's really expanded to some of these cloud things of looking at novel payment models, something we call HDI Advance, which is spreading what we've done outside of the CV service line, work in the supply chain, work with our intensivists, work with the orthopedic team and anesthesia team. And we've also done a lot of partnership with the MHI Foundation in terms of providing better access to more real-time data, particularly with Dr. Bradley's help in coordinating research projects and research interests and how we can best get that data to them in a more meaningful and efficient way that allows us through the foundation to do really groundbreaking research and analytics. And the other thing you see on the right is financial and operational analytics. We use our data warehouse and the cost accounting system to help us make strategic decisions about where the service line is going to go. Where should we make investments? Where should we maybe scale back? What's growing? What's the future look like? What's the demand for beds here in this almost billion-dollar infrastructure that's being built here? Data drives those decisions, and not having that data is really flying blind. So when you look over the last 12 years or so, we've had a significant impact both financially for the health system, a total of $120 million of net financial benefit to the health system that's been tracked in partnership with our finance team. But probably far more important is the little bubbles on the left, which are the quality impact. Avoiding over 3,000 units of blood is huge. Avoiding 3,000 hospital days, meaning patients were in their own beds in their own homes 3,000 nights compared to being here in our hospital beds. Avoiding over 1,000 ICU admissions by risk stratifying people post PCI to telemetry versus ICU and the like. This is all grounded in what's called an enterprise data warehouse. In 2005, Allina made a very bold strategic decision to invest in an enterprise data warehouse at the time that they went live on Epic as a medical record system on both the inpatient and outpatient side. And over time, that data warehouse has grown. It now has over 100 sources of data. Those sources, obviously, the biggest one is the medical record and Epic, but 99 other sources are cost accounting data, patient satisfaction data, registry data. You name it, it can be linked into the data warehouse, and you can derive additional insight into what's happening around clinical care and the cost of care. And so leveraging this data warehouse, we define metrics, clinical protocols, and changes to care delivery with a goal of eliminating waste and reducing unnecessary variation. And certainly, as you've seen, we try and closely track clinical and financial outcomes. This is one of many clinical dashboard examples, a heart failure dashboard, which anyone can access. It has really tremendous, robust detail on heart failure care across the Allina Health system. In this picture, it has about 747,000 hospital visits. This is an older picture. It's grown to just under 900,000 hospital visits. And you can look at patients based on their characteristics, age, systolic, diastolic heart failure, cause of heart failure, number of hospital readmissions, and really get a better understanding of who's using the resources and why they're being used, and who's getting the care they need and who's not. In the right, you see the value of our CHAMP clinic with Mosey Bennett and our advanced heart failure team that's worked hard around optimizing guideline-driven care management. So you can see in the CHAMP clinic, ACE, ARB, and ARNI is at 93% compared to national averages of 80%. Similarly, beta blockers, 94% compared to 81%. The ability to develop that clinic, to monitor it, to show its success depends on a robust underlying data infrastructure, as well as the clinical teams that do that care every day. Well, what about sort of operational management? As a cardiovascular program, we go to about 50 outreach sites across the state. Some of them we go frequently, some of them we go very infrequently. How do we know where we should go more, where we should go less, who should go, what kind of care is needed? We built an outreach dashboard which helps us to understand that, and it looks at both the upstream and downstream financial impact of going to a specific site, as well as the type of care that's received, the procedures that come out of it, the frequency in which there's no-show rates or cancellation rates and the like. And if you look back since 2017, we measure something called contribution margin per FTE day. So from a management perspective, what's the value of sending a cardiologist to any specific site to see a panel of patients that day? And it's related to the care that that patient gets in our health system over the course of a year, a few months before, 9 months after. And we measure that with something called contribution margin per FTE day. It's not the only metric of why we would go to these sites, and certainly we go to many sites to provide cardiovascular care in regions where you otherwise can't get it, and that's tremendously valuable, and I don't want to discount that with this financial measurement, but it does allow us to understand where we're putting our investments and where those investments are maybe not returning care to the health system. For example, many years ago, I used to drive 2 hours up to Alexandria, Minnesota to see patients. I would often see patients and say, I think you need an angiogram. And they would say, well, St. Cloud is pretty close. Can I go there? And of course, I'd say, yeah, I just think you need an angiogram. And that's great. But were we providing the best care? Was that fragmented? And were we providing value for our own health system by driving up there, seeing those patients, sending them to St. Cloud for their procedural care, and then seeing them back? This contribution margin per FTE day is a measure of that, and it helps us to understand that on a broader perspective. And as a result, in all honesty, we don't go to Alexandria anymore because it didn't generate the value that we thought it could. So MHI is an innovator and has been an innovator for many, many years, back to STEMI and Level 1 and a whole host of things. And some of the more recent innovations are Beyond 5, which was an effort to provide consistent, high-quality care over the weekend in a thoughtful way to improve hospital efficiency and to reduce length of stay and to improve the patient experience. When you look since 2019, we've tracked the impact of Beyond 5 as a program, and it's provided over $11 million in net financial benefit to the health system, and it's avoided over 1,800 inpatient hospital days by patients getting a pacemaker on Saturday instead of Monday, getting a non-emergent invasive angiogram on Sunday, or getting a CT coronary angiogram on Sunday, or by seeing an electrophysiologist over the weekend instead of waiting until Monday. All of those things have a significant impact on both the cost and the length of stay and the patient experience. What about optimal care for chest pain? Chest pain is a common presenting system to the emergency department, and in partnership with our ED providers as a high-volume CT coronary angiography site, we've developed a standardized protocol that evaluates ACS presentations. And when you look over the past 4 years, this has avoided just under 1,700 inpatient hospital days because you can get a CT through the ER and have an answer as opposed to staying overnight and having some sort of stress test or evaluation or cardiology consult and the like. And that has a significant impact on unnecessary spend. The bulk of that savings goes to the payers. The benefit of not being in the hospital certainly goes to the patient. But efficiency of care and getting to the right answer quickly is a benefit to all of us with our limited resources. Another example is risk stratification following acute MI, and this is a work in progress. This has been something that has been on my mind, honestly, for years, and I think we haven't mastered it yet. But when you look at patients who are admitted for acute MI, Some of them are high risk for readmission and some are low risk. And you can see that based on the data in the graph in the middle, the red bar versus the blue bar. So why do we tell all of them to follow up in 3 to 5 days with their primary care doctor and to follow up with us in a week? That's really not the best care, right? Those folks in the blue bar probably need a telephone call or an email or a text from an AI chat bot. Those in the red bar probably need much closer following. And so how do we do that, and how do we embed that into the care we provide instead of just saying everyone should follow up in 3 to 5 days? Management of supply chain costs is a significant area that we've leveraged the data warehouse and tried to embed clinical input into supply chain decision making. If you look just in 2023, a net savings of over 14 million through supply chain decisions. Used to be the CV Supply Chain Committee, now it's called the Non-Labor Governance Committee. It reviewed 110 product requests. 19% of them were declined based on the role of their clinical need and pricing. And in combination with the pricing pressure that's put on the suppliers from this committee, I think it's had a significant positive impact on the health system's ability to manage its supply chain costs. When you look at MHI's median total variable costs per case, which is in the graph below, it remains 28% below our highest cost site across the health system. And that's a marker of consistency and focus on the supplies we use. There's still huge opportunity and there's still variation, and there's more that can be done. But leveraging this type of data infrastructure allows us to see the opportunity, measure what we can do, and see what we want to do in the future. Well, what about population health? To effectively manage cardiovascular care, we need to focus on how we can best deliver care to the community in care models that best meet our patients' needs. One example of that was started many years ago as Cardiology Curbside, and many of you have participated in it or used its services. It's had a direct clinical impact on over 7,500 patients through those calls to the Cardiology Curbside. It's reduced direct patient care costs by $1.2 million, and it's saved our payers $4.2 million. And this is an example of where we need to leverage the data we have, the insight we have, and the work we do to partner with our payer relations teams and how Allina makes decisions in partnership with our payers so that the value that they're seeing financially can be translated back to the health system where appropriate to reinvest in these types of programs. We've expanded Cardiology Curbside recently to this concept called C5, which I think everyone who practices at MHI will agree is still a work in progress, but has had a lot of initial success. And the goal of C5 is to provide comprehensive cardiovascular care 24/7, to be able to provide virtual inpatient and outpatient care, to do those cardiology curbsides both during the day and at night, and to really be able to provide a plan and a decision for patients no matter where they present, whether they're coming to an ER and they need a plan for a cardioversion a few days later, or whether they need to see an electrophysiologist a few weeks later, or whether they need to be admitted to a quaternary center like Abbott, or whether they need to stay in a regional center like any of Allina's regional hospitals. Those decisions historically have not been made with consistency or structure. They're often made based on the clinical guidance or input of who's on call. And we've seen when we look retrospectively that there's tremendous variation there, and not all of that variation is what we call necessary variation or variation related to patient characteristics, which would be perceived as appropriate. A lot of that variation is unnecessary variation. And one of the goals of C5 is to better standardize the care that we provide and make those decisions in a more standardized structure so the patients who need complex quaternary cardiovascular care are transferred here, and the beds that are available are used for those patients and less for patients who don't really need that care. And Jonathan Erbach has been a huge benefit in working on some of these protocols and helping to guide the C5 structure, which we continue to build out. But when you look just at the first quarter of what's happened since we started this back in January, transfers for cardiovascular transfers from other Allina facilities to Abbott have increased by 50%. Non-Allina facility transfers have increased by 67%. And when you look at weekend subspecialty consults, all that B5 work has expanded even beyond what I listed in the B5 structure, has expanded on the weekends since January, with 126% increase in EP consults over the weekend, 35% increase in EP procedures, and an 82% increase in cardiovascular procedures on Sundays. We've seen the median length of stay decrease from 128% to 111%, and at the same time, we've seen the case mix index increase. All of those are going in the right direction for a quaternary cardiovascular hospital like Abbott, driving the type of care that we want to provide here, and identifying the patients that need to be here and not those that maybe don't need to be here, could be cared in other spaces. What about the outpatient side? We developed an integrated practice clinic in Eden Prairie with a focus on sort of coordinated care with our primary care group called ANGMA. And it was based around an article in New England Journal of Medicine, Catalyst, which was related to integrated practice units. And anyone who's been a patient knows some of these quotes, right? Healthcare does not have to be chaotic. Patients and families should not have to worry about coordinating their own care. And clinicians shouldn't have to worry about who are going to provide those services that their patients need. For anyone who's in healthcare, if you need healthcare, often you go and ask colleagues and friends, who should I see for this back surgery? Who should I see for my foot or whatever it is? What about patients who are not in the healthcare industry, right? They see a very fragmented, very challenged, very chaotic, and very confusing environment. And how do you make that smoother and better at reduced cost? So in Eden Prairie, we've started group classes. We all often will say the same thing to patients in clinic, right? We have little spiels about atrial fibrillation and the risk of anticoagulation and stroke and the like. So we started a group education class around atrial fibrillation where patients get those learnings, and then they have a 10-minute visit with one of the electrophysiology advanced practice providers for a patient-specific plan. The same for our heart failure group education classes. Dr. Bradley has worked hard on expanding the remote hypertension management program. I'll give you an example of that in a second. And then Dr. Miedema has helped with a prevention class. And all of these are efforts to educate our patients in a different way as opposed to repeated clinic visits one-on-one. The hypertension management has tried to leverage Track My Health and the Allina Health account, and it's a huge opportunity to better manage hypertension and the medication titration in a protocol and standardized way without repeated visits. We give patients an Omron Bluetooth-enabled blood pressure cuff, and it's gone through many iterations, but continues to improve and have tremendous potential to better manage hypertension in a more cost-effective manner. When you look at the integrated practice clinic overall, the volumes are significant and have exceeded first couple year projections. About a third of patients seen in primary care are also seen by cardiology providers in Eden Prairie. 40% of those patients that are seen in Eden Prairie are covered under Allina's different value-based care agreements. About 56% of them are covered by commercial insurance, and over 88% of them use the Allina Health account, which really should be the portal for everyone in our health system in terms of how they interact with accessing their care through Allina. It's also been sort of an area for pilots, and not all the pilots have gone well. We tried We piloted voice-enabled AI technology to listen to a patient visit and sort of transcribe the clinic visit and hopefully make documentation easier for the physicians. The initial round of that was sort of, I think, mediocre feedback, and most of those that used it didn't stick with it. There's a second pilot now because the technology has improved so significantly, and I think there's still huge opportunity to do that where we don't have to dictate or document everything, but computers and technology can help do that for us. Another example is our portable handheld echo software, Cosmos. We trained some exercise physiologists on how to use it. We've sent some of those images to a company called US2 AI, which automated interpretation based on those images, and then it can be overread by the cardiologist. So the Eden Prairie Clinic is sort of a pilot site for some of these new technologies. Not all of them are going to work, and we know that, and we're learning as we go, but it's a great place to learn. What about clinical gaps in care? We have among the best structural interventionalists in the country at the Minneapolis Heart Institute, and yet we do echoes on thousands and thousands of people, and some of those people have severe symptomatic aortic stenosis and haven't had definitive therapy. And you can see in our own population, again, leveraging the data infrastructure that we have, the survival curves of patients who have had definitive therapy and who have not had definitive therapy. 1-year survival of 76% compared to 94% in our own population once they develop severe symptomatic aortic stenosis, whether or not they've had definitive therapy. And when you look at the cost of caring for patients with severe symptomatic aortic stenosis who have delays in definitive therapy, it's about a 73% increase for those patients who wait greater than 6 months. And so there's opportunity to identify that as a gap in care and work towards making sure that they get a timely evaluation and consideration for a surgical AVR or TAVR. What about our ambulatory surgery center in Edina? This is the first cardiovascular dedicated ambulatory surgery center developed, unlike I think any in the country, where there's no physician ownership, there's no physician financial benefit. It's really about optimizing the care and site of service for procedural care to allow complex high-value care to be done at Abbott and to have that less complex care that can and probably should be done in a lower-cost setting to be done in an ambulatory surgery center. And we've done that. It opened just over a year ago and continues to grow in volume, and we continue to learn where it can grow and where it can't grow. I want to transition briefly to artificial intelligence, because artificial intelligence is going to continue to be a major player in how we deliver cardiovascular care, how we deliver health care in the future. And to be able to use artificial intelligence effectively, we need to have a robust underlying data infrastructure that allows us to know and understand our patients and apply the appropriate AI technologies. When you think about what prompted artificial intelligence to develop, supercomputers can now perform as many calculations in a single second as one human could perform in 31 billion years. Can you believe that? That's crazy. Global annual data generation is increasing exponentially, 175 zettabytes in 2025. So what's a zettabyte? Well, if you remember a DVD, and used to be a huge storage of information, stack all those DVDs together, it would wrap around the world 222 times. That's 175 zettabytes. I want to share with you just this little clip, which I think highlights why artificial intelligence is so significant, and it needs to be a focus of where our health system is thinking about in terms of investment and infrastructure. I hope this will play.
What is just being completely overhyped and is pure speculation versus what's legit and what I can theoretically wrap my arms around?
Look, I mean, here's the reality, right? Look around you today. Everything in your line of sight right now is the product of intelligence. Humans collectively, individually, have created everything that you see around you. And so the potential to take what has made us special, our intelligence, and try to automate that, paralyze it, speed it up, and make it widely available to billions of people on the planet is, I think, one of the most exciting missions that we could possibly do. So I think that's very reasonable for us to think over the next 10 to 20 years. This is going to be the greatest leap forward in productivity that our species has ever known, probably more so than the Industrial Revolution. If it's anything like electricity, and many people have been comparing it to that, then you'll see it absolutely everywhere, in every device, on every platform, in every part of your life. And so I think that, you know, if anything, we're understating the real potential of this new wave of AI in the next couple decades.
That was Mustafa Soliman, who is a researcher and AI entrepreneur. And as you can see, the power of artificial intelligence is going to change everything that we do. And as a health system and as healthcare providers, we really need to be thoughtful about how are we going to manage it, how are we going to incorporate it effectively, how are we going to use it, and where should it maybe not be used. So what is artificial intelligence? It's basically a machine's ability to perform the cognitive functions typically associated with human intelligence. And you can see on the right, there's so many different aspects of it: machine learning, deep learning, neural networks, chatbots, and the like. When you look at current opportunities in cardiology for AI, I talked about ambient AI documentation for clinical documentation. I'll give you an example of using echo analysis and interpretation, where AI can identify cardiac structures, measure chamber sizes, and assess cardiac function with really great speed and accuracy. It's certainly beneficial with arrhythmia detection. I don't know how many of you have an Apple Watch and have ever done your EKG or cardia or refer patients to get cardia, but all of that's going to continue to grow, and one of the values of C5 will be how do we take that information in when patients have that, so we can make decisions without sending them to the ER to get an EKG. Similarly, when a patient presents to a rural ER, using our point-of-care ultrasound technology for ER docs that maybe don't do bedside ultrasounds every day, capturing images, and I'll show you how the AI tells them how to get the best image, and then sharing that with us in our C5 center so that we can review those images and provide meaningful decisions. The future of AI is really, unknown, but earlier disease detection, predictive analytics, the development of novel drugs, and personalized treatment plans are all part of the power of AI, which will continue to grow and develop over the next few years. But there's no question that there's also a lot of risks with artificial intelligence. We don't always know what the algorithms that the AI technology is using. There's a concept of whether the physician should oversee that and make final decisions, or at what point do you trust the AI more than you trust a human decision. There's roles of bias and fairness, and certainly data quality, and having a robust data infrastructure is part of alleviating that risk. As a health system, AI governance needs to have a structure, and it needs to have a decision-making and investment plan about how and where the health system is going to invest in artificial intelligence, and making sure that that flows with the rest of our data infrastructure and the way we provide care in combination with compliance and the like. And this is an algorithm for that, and I think there's a lot of discussion that could be had about how we as a health system will engage in artificial intelligence to best leverage it as a new technology. Nevertheless, there's no question it's everywhere. Clearly's AI software, MHI is a center of excellence for this, and piloted their ischemia software, AI for wearables and cardiac rehab monitoring, AI for risk scores and how patients will respond to loop diuretics, and they continue to grow at an exponential rate. So how we can incorporate these and leverage these algorithms as they're developed is going to be a huge opportunity for us in alleviating the management of the growing demand and the shortage of practitioners. This is just a couple quick examples of, you can see the person is holding the image probe and sort of moving the echo image around, and you can see in the upper left, it's saying when it's got the best image, it's in green, and then it saves that best clip. That's what a ER doc can do, a point-of-care ultrasound in a rural small ER, and then send that to our C5 doctors. This is in Eden Prairie. This is the Cosmos software, which real-time labels the different chambers and the valves, and sort of also can help guide what the best image is for capture. Dr. Buckler and others are piloting a software called Evidently, which brings together data in Epic based on a patient's presenting symptoms to provide information. So if he's seeing a patient with atrial fibrillation, it pulls together all of the relevant information related to that, including heart rate, labs, CHADS VASC score, HAS blood score, all the things that you would want and need real time in a more organized fashion to allow decision-making at the time of care. And as Ami Bhatt said, artificial intelligence really needs to be renamed collaborative intelligence, because it's a collaboration between the human doctor and the machine to leverage the best abilities of both to offer improved care and efficiencies in healthcare. And I think it does need to be a collaborative process as we continue to develop it. Nevertheless, I think what Bill Gates said is also really true. The development of AI as a fundamental is fundamental to the creation of the personal, is as fundamental as the creation of the personal computer. It will change the way people work, learn, and communicate, and it will transform healthcare. AI is already being used to improve how diseases are detected and diagnosed, and in the future it will help accelerate research breakthroughs and make accurate, reliable medical advice available to those who never get to see a doctor. So I want to finish by just coming back to what's possible with robust data analytics and clinically driven insight. And I hope you've seen that all of this is possible and has been achieved in many ways with our HDI Center, even as we've just scratched the surface of what's possible for our health system, for other service lines, and really for expanding what we do in the Cardiovascular Institute. But focusing on data-driven insights that guide our strategic investments, focusing on reducing unnecessary variation and identifying areas for clinical care improvement, making strategic investments in value-based care arrangements and population health that are not always focused just on the outcome of the population or the community, but also take into account the financial impact and how we can support the finances of the health system as we transition into value-based arrangements. And certainly the role of physician leadership and clinical insight in making all these decisions is critical. So with that, thank you. I'm happy to have discussion or questions.
Craig, that was fantastic as always. Questions?
Thanks, Craig. That was great. So I know when we go to these national meetings like Midaxium, they always talk about data envy. And as I listen to your talk, well, it seems like data is critical. Having reliable, credible, usable data is important. But then coming up with an action plan or something that can change based on the data, or something that can be beneficial to the system is very important, how to use the data. But then the third element is how to translate that into action, really, by having clinical teams buy-in and governance structure to implement it. There's always a lot of the bigger the plan, or the bigger the change, the more challenging to implement it at multiple levels. You need buy-in from the system, from the physicians, change management. So out of these three, which one, in your experience, is the most challenging, and how would you balance these three? Because people always say, well, how can we do this? And it seems like they only think, oh, if we just had the data, we can do this. And you guys are so lucky because you have the data, which we are, because without the data, we can't get anything. So can you comment on these three?
Well, it's a great question. I'm going to start by saying I don't know the answer. All three of those are so critical, right? There's no question you have to have the data, and not just have the data, but understand the data, believe in the data, have all of our providers believe in the data, that it's accurate, that it's real time, that it's realistic. But change management is hard, and we've seen that. Deploying Beyond 5, deploying C5, these are big changes to the way we practice and the way we deliver care. As providers, we have questions about what's my medical legal liability when I'm talking to someone in Blue Earth about a decision. So I think all of those are critical, and I think having physician leadership that can understand that and clinical insight to help drive that are key components of it. I'll tell you that Allina in 2005 was a forerunner in the development of its enterprise data warehouse and its partnership with Health Catalyst. And I think today we're at an inflection point where we're either going to go in what I believe is the right direction, which is increased investment, a renewed focus on building out a cloud-based data warehouse, and more strategic investment in how it interplays with our cost data and our payer contracting data. But if we don't go that direction, then we'll lose what you described many of people across the country when they see us call data envy, because what we had has been great and it's allowed us to do a tremendous amount, but it's time for a refocus and reinvestment in where we go forward.
Excellent talk. I have two questions. Number one, I always feel like as a provider, when you mention costs, that I have no idea, we talked about it obviously before, but that I have no idea what I'm using, right? And my personal feel is if we go into value-based arrangement at some point, we as providers, right, needs to know how much his fanciest new Boston Scientific ablation catheter is versus the other one, right? And so we just don't have that access. And obviously there's a history of not telling us, not by you, but like healthcare system-wise, let's not talk to the physician about cost because we shouldn't influence their care. But I think that's not the future of this, right? Because we need to know it. So maybe you can make a comment there, and obviously we talked about it. But number two is the triple aim, evolved to quadruple and quintuple aim, and the fourth is the burnout of physicians, right? And so whenever we have obviously these tremendous developments, there's also a cost that comes with it. And how do we address that? Because we obviously are forefront at MHI, but we also work quite a bit to make this all happen. And how do we incorporate AI or something in it to reduce that?
Yeah, so those are both excellent questions. Let me address the second one first. I think burnout is a major issue, and I think making decisions that allow physicians to do physician-type work, advanced practice providers to do advanced practice work, is critical. And I think AI has the opportunity to do a lot of that. I think the data infrastructure that we have has allowed us, hopefully, to identify resource needs and to quantify the impact of big changes we make. For example, C5, that's a big investment by the health system in additional advanced practice providers, coordinators, sort of 24/7 roles. And we had to use the data infrastructure to show that both from a financial perspective and from a sort of care perspective, that was a better approach. I think we couldn't have done that without the data infrastructure. I think we need to do a lot more of that. I think we need to make sure that we focus on the role of physician burnout in particular, because it is a major challenge. And when you look at the shortage, part of that shortage is physicians saying, I don't need to do this. This isn't, best for me. And I think we can make things better. It's a work in progress. Your first question, remind me of your first question.
Visualize the cost, basically.
Yeah, so some health systems will give you a receipt after your procedure, right? Here's what it costs. Allina, for better or for worse, has not approached it that way. I'll tell you that one challenge is that the current cost accounting data infrastructure, which used to be good, is now poor. And That's a reality. And so even if they said, hey, we want to give you the receipt of here's what it costs, I wouldn't trust it, without a lot of cleaning and a lot of analytics. I think we're working towards getting a better cost accounting infrastructure, and we need that cost accounting infrastructure to talk with all the clinical information. Now, whether a provider should have that receipt, I think is more of a cultural decision. For MHI, the approach has been, if we manage at the institute level what comes in to the health system, what's available to you. If you identify the best new catheter or whatever, you bring it to the supply chain committee, we review it, we talk with you and others about it, we often pilot it, we look at the costs, at the clinical outcomes, and we say, is it worth having on the shelf? And I think that's, in my view, the best approach in making decisions about what should be on the shelf and making sure that it's priced appropriately, and then still letting you as a proceduralist have anything you want on the shelf, 10 of them, 5 of them, 6 of them, whatever you want, from a clinical perspective. Is that right for everyone? I don't know. I think many people would say, I just want to know how much it costs. And,
Maybe not 10 of them.
I was gonna say what Craig said at the end. I think the way this has been managed is upstream. I always worry about going to my, let's say, EP partners and telling them, well, every time you see a patient, you have to make a decision whether to use an MRI compatible pacemaker or not. There are certain things there's clinical judgment in, and there are certain things that are driven by kind of the balance between what is important for patient care, which always takes precedent 100% of the time, and the cost. So I'd rather work with Craig Strauss negotiating with the companies and making sure that the delta is zero, which we did, and let you not worry about it. Now, if you come and ask for something like the Versa Cross Transeptal, then we would engage everyone who asks for it and show that the clinical value is not there and just not approve it. Whether that's right or wrong, I don't know, but I think this is how we've been managing it. And part of it is, again, you get it and you're $500 more than the person next to you. We have not gotten to a level where the delta within MHI is that significant that we need to hold individuals accountable as long as we manage things upstream. Is that fair to say?
Other questions?
Thank you for your presentation. It's exciting to see the power of data at work here at MHI. My question is around the algorithms and the data used to make clinical decisions. And for those patients who don't fit the algorithm, essentially the outliers, I'm just wondering from a data perspective, what you all are doing to learn from those patients and capture those and making decisions.
Yeah, that's a great question. So, generally speaking, a good algorithm is going to be appropriate 75, 80% of the time, and 20% of the time there's going to be outliers. And I think our goal, and honestly, Jonathan could speak to this, is to provide physicians with the framework to make those decisions, but always have the latitude to deviate from those algorithms. And when we track things from a analytic perspective, retrospective or even prospectively, we don't exclude any of those. We can certainly identify the outliers and we can learn from them, but we typically don't exclude them. And I think there's a lot that you can learn from the outliers and how we can manage things better. That's one of the ways that we've changed protocols in CV surgery, for example, where we looked at patients who had readmission and what was the driver of major driver of readmission, and in mitral valve surgery it was related to fluid management and stuff, and there were some changes that were made in discharge diuretic planning that has significant impact on that. So I think outliers are a way we can learn and make changes to the algorithm, but nothing's ever going to apply to everybody.
We have some online questions?
Yes, we actually have 4 online questions thus far, so let's see if we can rapid fire through these. The first comes from Barb Chaco, and Barb is asking, are dashboards and EDW combined with Vizient for understanding our outcomes?
Yeah, good question. Well, first I want to thank Barb for everything she does because she's a phenomenal part of the team and registry and whatnot. Vizient brings important data, I think, in terms of comparisons of health systems and some health system specific data. It's all sort of coding based and whatnot. And back to the point I made about where Allina is going in terms of its investment going forward. One of the challenges has been bringing Vizient data into the enterprise data warehouse to link it with the rest of the data we have. And that's been a slow and delayed process. And I think that's a misstep on the part of our health system because Vizient data is helpful, but no one source of data, even the medical record, even the payer contracting data, even the Vizient data, you can't make, real informed decisions based on any one source of data. And so bringing that Vizient data into our enterprise data warehouse should be a priority, and we should leverage it and link it, and we haven't yet.
Thank you. The next question comes from Dr. Lesser, who says, wonderful talk and work. His question is, what system is in place to be certain that the data collected is accurate? Do you or we and HDI have routine access to the decision makers in Allina?
Yeah, that's a good question. So in terms of data accuracy, I think there's always room for improvement there. Garbage in, garbage out. We don't control every clinician's documentation of everything. There's a lot of things we can do, and partly overlaying some of the AI algorithms allow us to do it even faster and better. But we do a lot of what we call data validation, and that's a big role of our data analysts. And we have some really thoughtful and I don't know what the right word is, but very detail-oriented data analysts that can really identify, small hiccups in the validity of data. So I feel pretty confident in the data we have, but that's on the clinical side. On the cost accounting side, I think there's opportunity for improvement. And to the second part of the question, do we have access to, the decision makers? I think that's really an opportunity for improvement. I think we do, but I think that there's opportunity for significant improvement as a health system in making strategic decisions about how we bring data into the data infrastructure that flows together. Because when finance makes decisions about the best cost accounting software, it may or may not be the best insight that's available to integrate into the data warehouse. And so there's opportunity for improvement there.
There are two left. The next being from Dr. Hauser, and he's is asking a financial question. Essentially, the question is, does MHI or Allina benefit financially when it saves money for payers, i.e. a bonus?
That's a good question. So, yes and no. Our ambulatory surgery center gets about $500,000 population health financial benefit from the commercial payers for which services are provided there, unrelated to the procedural payments. So there is some financial benefit, but the reality is linking what we do to our payer contracting has been an area that we have not, as a health system, have not done as well as I believe we could. I think there's millions and millions of dollars left on the table related to that.
Thank you. There's one final question. Sorry, I know we're at time here. It comes from Tom Gunderson, and he's asking, can you comment on the near-term opportunities and how AI can help us with MHIF clinical research?
Yeah, that's another good question. So, you take some of these big learning models and stuff and you sort of give them everything in the medical record, and a lot of the software can identify patients that would be candidates for different studies, and there's companies out there that will do that. And I think, whether or not MHIF and the health system want to invest or partner in those is still a decision in process. But I do think that there are opportunities to better identify patient candidates for research. And I think that there's also opportunity on the retrospective research side to far more efficiently do research and analytics using AI software. I think that's going to continue to grow exponentially over the next couple of years.
Thank you.
Well, Craig, it's clear that we've had the benefit of you and a 10-year lead time to most programs, including the health system. And I'm hoping through your leadership and what you've been able to do here, we can continue to scale that and spread that. So thank you so much for a great, great Grand Rounds.
Yeah, thank you.